Hi everyone. Welcome to Department of Medicine Grand Rounds. I'm Adrian Lazarevic-Olquist, one of the inpatient chief residents here at UW Montlake. Couple general housekeeping notes. We will have our presentation from David, and then after that, there'll be the presentation of the Evans Award. So please stick around at the end to congratulate our awardees. In what will be my last introduction to Grand Rounds as the chief resident, I have the very great pleasure of introducing my co-chief and friend, David Rink. David received his undergraduate bachelor's degree in chemistry from the University of Georgia, and then attended Emory University School of Medicine and the Rollins School of Public Health, where he received his dual MD and Master of Public Health and Epidemiology. After medical school, he came to the University of Washington, where he completed his residency in internal medicine and honed his natural teaching abilities as a member of the clinician educator pathway. He is currently a chief medical resident for the internal medicine residency program here at the University of Washington Montlake, and will soon be traveling to Ann Arbor to start his fellowship training in pulmonary and critical care medicine at the University of Michigan. And I want to say on a personal note that I count myself very lucky to have David as a good friend whose quick wit and good humor I appreciate enormously. I am frequently struck by the thoughtfulness he brings to the practice of medicine and to medical education, and especially his uncanny ability to strike right at the heart of a complicated issue and to convey his thought processes clearly and concisely to bring those around him along with him in the process of finding solutions. I think he is a thoughtful person and a natural leader. And it has been one of the more enormous professional and personal privileges I have had to spend this year working alongside him. And I am sad for my own sake that he is leaving our shores, but I am very excited to see what the future holds for him. With hopefully just the right dash of teary sentimentality on my part, and with absolutely no further ado, take it away for Grand Rounds, David.
Well, that is extremely kind of you, and I will do my very best to uphold what you have just shared about me in today's talk. Um, Good now, 2 minutes into the afternoon, everyone. Thank you for joining for this. I have the distinct pleasure of giving the penultimate Grand Rounds of this academic year. And today I'm excited to talk to you about a topic that has been a real pleasure of mine and a joy of sort of thinking about over the last couple of years, and that is supporting learner autonomy in an era of increasing supervision. Um, I will start by saying that I have no financial or otherwise conflicts of interest to disclose. I do want to share, though, that regarding content, each of us have different practices or expectations, and we are all inherently pulled towards our own personal experiences. And with that, maybe not before so much as we begin, I just want to ask that each of you, to yourselves, reflect on your experience with autonomy versus supervision during your training. For those of you in an attending role now, how was your experience different from the current state? And then for learners, what does the ideal state of autonomy mean to you? And how does your perception of autonomy influence your patient care? As you reflect on that, I'll share our objectives today. So I'm hopeful that today we will describe the tension between supervision and autonomy for residents as they progress towards independent practice. We will review current cultures and practices from the resident and attending perspectives, and then we'll examine individual and programmatic best practices for promoting autonomy for residents. First, we'll start with a brief background. It is hopefully no secret that the major overarching goal of graduate medical education is to transition residents from supervised to independent practice. This process of residency is rooted in an apprenticeship model with high levels of autonomy. There were historic, largely time-based expectations for growth, the central premise of which still remains. However, overlaid on those time-based expectations are increasingly emphasized competency-based frameworks. Now, these changes and lack thereof have occurred in the setting of a shifting clinical training landscape with new, unique, and changing clinical, business, and societal priorities. Importantly, from the perspective of the trainees, recent data increasingly suggests that autonomy is necessary for professional development. These tensions are summarized nicely by this quote from a JAMA Internal Medicine commentary in 2018, which says, "To help guide young physicians towards independent practice, we need as much time with our trainees as we can get, but really only as much as they need." And it is in attempting to square that circle that we find ourselves today. So, how did we get here? Understanding briefly the evolution in duty hours for graduate medical trainees can help us situate this conversation about where we are now with resident autonomy. Formal graduate medical training is only about 150 years old. It started at Hopkins in the late 19th century, when residents lived in the hospital and were essentially available 24/7 to care for patients. While the call schedule evolved over the 19th century, this practice of living in the hospital remained. And this is where our term house comes from. House officers or house staff were residents whose home was literally the hospital. Even when the ACGME was formed in the early 80s, work hours remained unregulated. In 1984, there was a seminal event that occurred, which I'll talk more about in a second. But the death of Libby Zion catalyzed a national conversation around work hours. And in 1991, the ACGME set an 80-hour workweek mandate for 4 specialties, including internal medicine. With increasing attention to medical errors and patient quality and safety, this 80-hour rule was finally extended to all specialties in 2003. Many of you may remember the story of Libby Zion, but for those who are unfamiliar, it was a watershed moment in graduate medical education. Libby was a young woman admitted to a New York City hospital overnight with fevers and myoclonus. Residents saw her in the emergency department and spoke with an attending by phone, but no attending ever saw her. There was a lot of diagnostic uncertainty, and overnight she received meperidine and haloperidol. She developed increasing agitation and ultimately had a cardiac arrest around 6 a.m. and died. Afterward, her family became extremely concerned that she was never seen by an attending, and their advocacy and lobbying efforts triggered a cascade of events that eventually led to duty hours reform. 15 years later, the Institute of Medicine put out their report titled To Err is Human, Building a Safer Health System. The report was a policy document that discussed the impact of medical errors on patient outcomes. It described how faulty systems, processes, and conditions lead to mistakes and the failure to prevent them. The report's message was that people who make mistakes should not be blamed or punished, but instead it's the systems that should be examined. It highlighted that most medical errors are the results of system failures rather than individual actions, stating that there are good people working in bad systems. One outcome from this report were new expectations for attending supervision over clinical decision making. Soon thereafter, the ACGME mandated duty hour restrictions for residency training programs. Initially, there was an 80-hour workweek limitation, but there were additional restrictions that were imposed several years later. With the caveat that downstream effects of these changes are pretty hard to study, given all of the variables involved, the outcomes from the studies have been somewhat mixed. Studies show little to no improvement in patient outcomes. There are mixed results with regards to educational outcomes, and there is some signal that there may be some improvement in some metrics for trainee wellness. So where are we now? We are not advancing. There we are. I think few would argue that alongside the series of events, as well as this series of events, as well as other events that we haven't yet touched on, such as the evolution of hospital medicine, increasing medical complexity, and then the electronic health record, there's been a paradigm shift away from autonomy towards a more supervised clinical learning environment. However, I would be remiss if I did not pause here to emphasize a common pitfall. That is, autonomy and supervision should not be conceptualized, as they so commonly are, as strict antonyms. Indeed, autonomy is not necessarily all good, nor is supervision by default bad. If these were true, then what would be the purpose of attending at all? Indeed, just as trainees are not monoliths who all need the exact same thing to reach that goal of independence, we must recognize that it is in finding and adjusting a balance of autonomy and supervision that is the essential task of supervisors. So that turns us to the literature. It turns out that I and my mentors, who I was fortunate to work with, Gabby Berger and Tyler Albert, are not the only ones who are interested in the balance between autonomy and supervision. So this is a recent study from a group at UCSF. This study compared trainees and attending perceptions of autonomy and supervision on the inpatient wards. It was done right at the beginning of the pandemic. It was a sequential mixed method study, starting with resident and attending surveys, and then going on to focus groups. They had response rates of almost 50% for the survey, with 76 residents and more than 100 attendings, and then 46 people attended 14 different focus groups. They asked residents and attendings about the current culture at each of three hospitals, the university, county, and VA, with 0 on the scale being entirely autonomous culture and 1 being entirely supervised. As you can see, trainees perceived the current culture to be more autonomous than attendings did. And there is a difference between hospitals, with the perception of less autonomy at the university hospital. They also asked what the ideal culture should be, and nearly everybody felt that there should be more autonomy and less supervision. Of note, you can see that the attendings at the VA hospital actually felt that the current balance of autonomy and supervision was spot on, with 0.38 being current and 0.38 being ideal. The authors then used the focus groups to create a schematic of the interrelationship between what they felt were the 5 core contributors to the autonomy and supervision balance. Most distally was the institutional factors, including culture, and more proximally, we see the contributions of attending, trainee, and patient, both individually and then particularly interpersonally. I would specifically highlight their attention to dynamic supervision in the interpersonal, where attendings titrated their level of involvement and engagement in daily activities based on a team composition, scaling up on resident days off, and then scaling it back down when the team is whole again. Which segues nicely into a study that I was fortunate to conduct, again with the mentorship of Gabby and Tyler, that further explores perceptions of autonomy and supervision among current internal medicine residents. This was a multi-institution study, survey study of senior residents at 9 academic internal medicine programs across the country. These programs were large, geographically dispersed. Each had residents rotating in a 3-hospital system, including a safety net, university or quaternary center, and a VA hospital. And we also had close to a 50% response rate with the associated demographics you see here. We asked a series of questions which explored the perceived experience of residents at all 3 clinical training sites within domains of autonomy previously described in the literature. Those are leadership, communication, and medical decision-making. And in this figure, you can see the results of the 5 questions. Each question had 3 parts, reflecting each clinical training site within a program. Starting on the left, we see that residents responded that they perceived attendings at the university sites were more often leading rounds than the senior residents, as compared to safety net and VA sites. This pattern carried throughout our questions, as you can see for numbers 2 through 5, where, respectively, residents were more likely to need to discuss patient care plans before enacting them. Attendings were less likely to allow for alternative safe and reasonable plans to be enacted than their own. Residents were less likely to be involved in key communication about patient care. And residents were less likely to perceive themselves as the leader of the medical team at university hospitals. Importantly, all of these differences were statistically significant between university sites and the other 2. However, we think it is worth taking away from this that the absolute difference in the domain of communication is smaller, such that we are overall doing better there than with the other 2 domains of leadership and medical decision-making. We also specifically asked the residents to comment on their perception of attending oversight or supervision and their autonomy at the 3 sites. And we can see here that while most residents felt both were just right, about 25% of residents felt there was too much oversight and not enough autonomy at the university site. Now, there are likely many reasons underlying these differences. some of which we believe can be explained by the prior figure's results surrounding residents' perceived ability to exercise autonomy via leadership, medical decision-making, and communication. We did, however, specifically ask residents about patient complexity, and importantly, they did not feel that differences in patient complexity completely explain the differences noted here. We also gave respondents an opportunity to offer free text responses about their perceptions of those who chose to leave a comment. This is the breakdown of themes noted from those comments, wherein respondents felt that supervisors were the most important factor in the autonomy experience, followed by structural and cultural elements, including the site and rotation or structure of that rotation, such as the presence of days, swings, or night shifts, the presence of a supervisor, the need to staff or when staffing occurs. So with these results in mind, we believe we can push this model a bit further. Each of these roles, the attending, the trainee, patient, is critical in the trainee autonomy experience. And we can deepen the understanding and impact described in the UCSF model by layering these practice domains within the interpersonal. And attending can then more concretely practice dynamic supervision by considering how they empower trainees to be leaders or medical decision makers, therefore directly influencing the autonomy experience. Which brings us to the concept of learner empowerment. So what does it mean to empower learners? There isn't a universally accepted definition here that I'm aware of or could find in the literature. But I would argue that empowering should imply the promotion of self-sufficiency. Qualitative data in internal medicine trainees from Adam Sawatsky and his group at Mayo tell us that autonomy fosters buy-in, connection, and meaning to and from our work, which cultivates an intrinsic motivation to grow. That implies that providing appropriate autonomy should empower learners. Simple, right? We are, of course, left with some pretty big questions, though. So how do we measure and provide appropriate autonomy? How do we assess readiness for independence? Recognizing that these are problems to be addressed both in an ad hoc, such as an individual supervisor, as well as a summative or program or profession-wide manner. Now, we can learn from our colleagues in the surgical space who have probably done a little bit more work in this regard and have more models developed in this space. So this is one model quantifying surgical supervision called the Zwish model. I believe it's from a group out of Northwestern. In this model, residents demonstrate behaviors commensurate with the level of supervision, which is then matched by attending behaviors corresponding to that level of supervision. And then when a resident begins to demonstrate the appropriate cues for advancement, the attending can then begin to progress to the next stage of supervision. For example, early learners will be in this show and tell stage, in which they open, first assist, and close during the operation. The attending matches their level by performing most of the key portions of the operation, simultaneously narrating and demonstrating key concepts. When the learner begins to demonstrate active anticipation of the attending's needs, the cue for advancement, the attending then advances their behavior to the next stage, and so on. With the framework for supervision or autonomy in mind, any individual supervisor or a group like the ACA-GME or ABIM can then select or define an expected scale of or progression for trainees. So at the top, we see at this institution, faculty and residents were asked to rate the expected performance of trainees at different PGY levels for different procedures. These ratings varied slightly between residents and attendings, but generally correlated. Alternatively, at the bottom, a scale is defined here in our own internal medicine program at UW for this particular task or skill. In this case, provide the initial workup and treatment for a solid organ transplant patient with signs of infection. and we hope to see progression over time. This particular example was me, and this particular supervisor was Dr. Brachet. She is sworn to secrecy as to whether or not it ever advanced beyond this level of partial supervision, but we're gonna leave that there for now. Um, Importantly, though, these tools are not without problems. First, it is generally easier to define discrete levels of supervision or assistance with a hands-on task like a procedure compared to more cognitive tasks. As well, these tools tend to work best in a summative rather than ad hoc fashion, wherein when we have more data can inform our understanding of a trainee's aptitude. This is especially true when we don't even provide these scales to all of our supervisors until the moment we ask them to complete an evaluation. However, there is still a role for ad hoc assessment when you can say that in general, a PGY X should be able to perform Y task with Z level of supervision. That allows for a baseline to approach any new learner from which you, the supervisor, then must adapt based on what they're demonstrating back to you. And to drive the point home, here is exactly why this is far from a concrete science. So in this study, using those same surgical scales as before, a significant gap emerged when they actually went into the operating room. You can see the lines suggesting what both faculty and residents expected, and then on the right, the very significant departure from expectation to reality. And this gap was present for nearly every procedure they studied, from simple local excisions to complex colectomies. In this population, trainees uniformly required more supervision than the model defined by both trainees or supervisors predicted. Now, a number of reasons were proposed for this, unsurprisingly, including duty hour reform. However, one of the more interesting themes that emerged was a general discordance between identified learning goals and relative importance of different aspects of management. They said residents have fewer learning goals for a procedure and are often centered on the technical aspects of performing the operation. Conversely, faculty have many more goals for each operative teaching encounter, and those very commonly include preoperative and postoperative decision making, topics which the residents felt were unimportant. Attendings identified entirely different aspects of management that were important to each case, which meant that trainees were assessing their preparedness using an entirely different scale. Faculty most commonly identified anatomy, natural history of the disease, patient outcomes, and procedure choices. Residents identified instrument use and selection, suture selection, and operative field exposure. In fact, those topics that were most important to faculty were often identified as least important to residents. Now, you may be quick to blame the residents here for this, but it really emphasizes the value of communication and expectation setting. It is hard to succeed when you do not know what you do not know. This applies across specialties. Here's an example from a study by Bob Dixon and Randy Curtis back in 2012. They sought to examine internal medicine trainees' self-assessment of end-of-life communication skills compared to assessments from patients, families, and faculty evaluators. This is a scatter plot showing that association, which is kind of a confidence versus competence plot. And as you can see, it is scattered. There was no association between the two. Competence and readiness are challenging to assess not only in learners, but within ourselves. We can see and all intuitively know that this is not a one-sided issue. Educators cannot be expected to single-handedly facilitate the transition to independent practice. So if empowerment is a two-way street requiring the buy-in of the learner, what is it that we as educators can and should do to promote that? Well, one might be tempted by tools like this in the background, a checklist published by the American College of Surgeons for trainees to use to increase their entrustability and intraoperative autonomy. This is certainly not a bad thing and could be one tool worth employing, but I would caution that simply transferring the onus or potential blame onto the trainee would be ineffective and disempowers you and the opportunity you have to cultivate their growth. So I again turn to the work from Adam Sawatsky and his group from Mayo. They argue, and I very much agree, that we should reconceptualize autonomy not as a synonym for independence, but as a source of motivation. It provides opportunities for trainees to develop their identity as physicians. This gets at a concept explored back in the 1990s in undergraduate medical education that was derived from motivational psychology called autonomy support. Autonomy support posits that supervisors do not give autonomy, but rather they support learners exercising autonomy by providing these things: choices and information necessary to make them, meaningful rationales for suggested actions, acknowledgement of feelings and uncertainty, and encouragement to choose and persist in those choices. We take this concept of autonomy support and we recommend going a step further. Conceptualize it as a procedure. Why? Because when we perform procedures, we do so with intentionality. We make a plan, and it is this intentional planning that sets us up for success. Because learning environments, psychological safety, and particularly learner development require this preparation, communication, and intentional individualization. So what should this planning look like? First, we recommend introspection. You have to first understand what you are bringing to the learning environment, inclusive of your identity and biases. Next, take an interest in every learner you work with. Make a point to learn about their identity and background. Then, and only then, you can work together to identify a set of collective goals, recognizing that that set of goals includes their goals, your goals, and then the broader goals that are of the program they're in and the profession we all are in. After that groundwork has been set, you can synthesize by asking this question: how can I, informed by my background, experiences, knowledge, skills, goals, and biases, work with this learner, not a different one, but the one that's in front of me, accounting for the same things in them to accomplish our mutual goals? Which brings us here. Together with Gabby and Tyler, and sort of informed by experience, as well as a review of some previously published thematic analyses, we developed a toolkit of recommended practices to apply as you transition from synthesis to inaction. The first is expectations. As we discussed before, we cannot succeed when we do not know what we do not know or what is expected of us. So expectations must be discussed explicitly from the beginning to set up learners for success. Without expectations, we can only fail as learners. Next, threat mitigation. It is essential to acknowledge and explore threats that may be faced by trainees. These include internal threats like stereotype and imposter syndrome, as well as external threats. The reality is that racism, sexism, hierarchy, and cultural issues pervade medicine today. Next, think about your presence. Both physical presence when you're there, as well as your remote presence and how you're checking in. When physically present, think about entering the room last with patients. Stand at the back. Consider allowing the team to round without the attending where possible, or if that's a thing that the trainees would like. Next is style. Allow learners to enact safe plans, even when different than yours. We saw this in our survey results, that there were significant differences between our sites across multiple institutions, where trainees at sites where they felt they had less autonomy correlated with this question around whether or not they were able to, or they felt like they could enact their own safe plans. So this is an easy place to intervene. Leadership. It's essential that you uphold the trainee as the team leader, both within the team and among the team members, as well as outside with patients and consultants. One way you can do this is situate yourself as supervisor as a consultant. Position yourself such that the trainees need to intentionally come to you or reach out if they have questions. It's a way to allow the trainee to act as leader and then to initiate that consultant contact when needed. Next, flexibility and adaptability. Two sides of the same coin. Flexibility being your willingness to adjust who you are and what you do, and adaptability being your ability to then adjust. One can be flexible but not be adaptable. In those situations, it can be very helpful to seek coaching. Remember that even coaches need coaches, and some of the best coaches have their own. It's one way that you can identify needs in learners that you are struggling to adapt to, and then find somebody who might be able to help coach you through that situation. Next is communication. This is what you say, as well as what you choose not to say. It's how you say it, it's who you say it to, and when you say it. It's all aspects of this. One thing you can think about doing is asking permission to share thoughts. Again, if we're placing ourselves in that consultant role, that's a way to step back. And at the end of an encounter with a patient, you can then say, would it be all right if I shared a thought? Next is iterate. It is a privilege we have when working in this space that we get to continuously work with new learners. And that allows us to continuously reinvent ourselves and learn from both positive and negative experiences in the past, mistakes we made, things that went well, feedback we received. So be intentional about seeking feedback from learners, both during and after working together. Use that feedback and feed it forward to your next experience with learners. And then last is modeling, paired with handing it back. If you have to take control of a situation, thoughtfully hand it back to the learner. And I want to actually highlight this point because I think it's really worth keying in on here. Because I think a lot of us who work with trainees, and I say that as somebody who's only recently started to do so in a supervisory role, but have this like, what if I need to take over? What if I identify a situation that seems unsafe or they don't seem prepared for? And I would argue that this should happen. We should be striving to empower learners to practice on the edge of their skills. If you identify a situation that you need to intervene on, do not hesitate. And then, when it is safe to do so again, hand it back. This is important because it shows learners that they are practicing on the edge. It is important because it gives you the opportunity to model managing a situation. And then when you very intentionally hand control back over to them, it re-empowers them. So these situations can absolutely add rather than detract to the learning experience if handled well. And lastly, I do want to touch very briefly on programmatic practices, applicable to both individual training programs and institutions. While attending practices were highlighted in our survey as the primary factor in modulating the autonomy experience, we also saw that site, structure, and rotation were all recurring themes. So through thoughtful efforts, programs can make headway in promoting autonomy and professional development for trainees. Starting with the foundation of intentional learning environment um, and rotation structures, which are likely to be best developed in partnership with administrative and hospital systems, you can create spaces and experiences that promote rather than detract from autonomy. So think about your supervisory structures. Who is present and when are they present? What are the staffing practices involved? When do trainees have to staff new admissions or changes in patient um, situations, changes in patient status, rather? Think about the presence of swing rotations, nights, and overnight call, and how those may be good or bad for the trainee autonomy experience. Next, it's essential to set deliberate expectations around attending and trainee practices. These should be clearly messaged to both groups. And you can pair this with the creation of focused faculty development that emphasizes, reinforces, and builds upon those skills. Recall those evaluation scales from earlier. If those are the metric to measure trainees on, distribute them before, not after faculty work with trainees. It's important that we all are working from a shared understanding of what is expected. Again, those expectations are essential in order to ensure that our trainees can be successful. And perhaps most importantly, the promotion of psychological safety and encouraging learners to manage up. These are essential in creating successful, sustainable programs that promote trainee autonomy and development. If you create an environment where learners feel they can fail safely, where they have a sense of agency, you will have succeeded in promoting autonomy. And if I could leave you with just a few final thoughts, learner autonomy remains critical for professional development despite increasing pressure for supervision. The trainee autonomy experience is impacted by institutional and interpersonal dynamics, and it seems that the attending is most impactful. We should be striving to support autonomy through intentional planning. Medical decision-making, leadership, and communication are modifiable domains to impact the autonomy experience. And importantly, know yourself and know the learner. Individualize and communicate with them, adapt when needed, seek feedback, and empower learners to fail safely. If I could close with a few acknowledgments. The list of people who have helped me reach this point is far too long to include here, but there's some key people that I absolutely have to mention. This work and me being here would not have happened without the tireless mentorship, sponsorship, advocacy, and general tolerance of me from Gabby and Tyler. I cannot thank the two of you enough, and I hope that if I'm unable to pay it back, at least I can pay it forward someday. James Wojtkowski, former chief here, was hugely instrumental in the conceptualization and review of these projects. Brad gave me a job and time and space to work on these projects and help push them towards publication. My wife, I have to mention for so many reasons, but in particular is just the main reason I'm even at the University of Washington and had the opportunity to meet and work with all these people. And then lastly, my incredible, inspirational co-residents, my co-chiefs, especially my friend and UWMC counterpart, Adrian, and the whole Gitku family. These 4 years in Seattle have been honestly some of the best of my life, and it's entirely because of the family I now have here. Moving 2,700 miles from home for residency, while not entirely unusual in the nomadic life of medical trainees, felt like a really big step. And I didn't ever imagine how worth it that big step would be. I'm staring down another 2,000 plus mile move to another new home, and I'm going to obviously miss this place dearly and these people especially. But it is in fact knowing them and having had this experience that I know the next one's going to be really great. So with that, I want to thank everyone again, and I am happy to take questions as time allows.
David, thank you so much for that really wonderful presentation and for well, everything you do and have done. There is a question from Dr. Petraji in the chat that I'll read out. So, excellent presentation, David. The data you showed about the difference in leadership opportunities and autonomy from attendings at the university hospital to a safety net hospital is very interesting. Could you comment if you have thoughts on why the differences exist by site? And do attendings also tend to gravitate to certain settings to be teachers because of those differences in autonomy?
Great question. Thank you, Dr. Petracci. I appreciate that. There's a lot of layers here, and I will say that our study itself probably does not have any conclusive data to point towards why this difference may exist. We did see some interesting comments in the free text responses that help, and certainly I have my own theories. Maybe I'll start with the latter question, which is, do attendings gravitate to certain settings to be teachers because of differences in autonomy? There were actually some comments that suggested trainees felt like that might be true, that there could be sort of this self-perpetuation of different cultures come to exist, and that attracts attendings who are interested in practicing in those cultures. There are there's obviously not evidence necessarily to suggest that that is conclusively true, but it's something worth pondering if there is self-perpetuation there. The broader question of why this difference may exist between university to safety net hospitals, there's so many potential reasons this could be true, and the reality is there's probably many competing factors. Um, we did ask the question around patient complexity and how that may impact things, and I'm certain there could be some role that there may be more complexity requiring more subspecialty management that just sort of inherently means more hands are involved that detracts from some of the autonomy experience. Um, I think that we don't have any evidence to suggest this is true yet, but there's interesting questions around equity that have been raised, and if the different populations served at these hospitals may play some role. I think the big take home for me of all of this, though, is that we have no data to suggest that increased autonomy affects patient or increased supervision rather affects patient outcomes. Like not a single study that I found really points in any conclusive way that that's true. And so if we know that promoting autonomy, which may mean some shift away from increased supervision, is good for trainees, then it is in fact the model of the VA and the safety net that we should be potentially trying to employ at the university if that's good for trainees and does not harm patients. Um, Lots of interesting questions brought up by the study. More work to be done for sure, though.
I'll give it another moment or two for questions if folks have them, and then we'll transition to our awards presentations. So
I'm going to take the interim chair's privilege of the fact that I'm on the panel to turn on my camera so I can actually ask you the question. Um, so first of all, David, thank you so much. I felt like that was an outstanding presentation, but really, I think a new lens for lots of us as we think about this, which I really appreciate. I'm curious. I realize you're going to be a fellow and you're an attending now, and then you're going to be an attending later. So I'm not going to ask you about the science. I'm going to ask you about the impact on you as a person and how this experience has changed who you are as an attending and how it will change who you are as an attending in the future.
Um, Fantastic question, one that I must say I've reflected on every day, both in my, like you said, sort of your interim chair. I'm interim attending is the way I like to think of it. So this year has been such an interesting time, right? Because one, it has allowed me to dig into this work more, right? We've had these results, we've been thinking about what they mean, and then simultaneously, I have taken on a new role, and so I certainly, like everyone, brought my own biases to this work, and the bias that I initially brought was that of trainee. And as I've gone through this work, I have increasingly become supervisor, and the first reflection for all of those who are supervisors here is like, wow, that's really hard. I just want to like put that out there for everyone that I had clearly a one-sided perspective coming into this, and I was just like, it's just give us more. We just need more autonomy as trainees. That's the easy answer. And then when I became a supervisor, I was like, actually, hold on a second. That's maybe not the right answer. Um, this work, I think the biggest takeaway for me and I hope that I stress this enough, I'm sure you guys are tired of hearing the word, but is the intentionality and individualization, right? It is the recognition that I, as supervisor, cannot perceive trainees to be monolith. Each one is different. Each one needs a different thing from me as a supervisor. And if I walk into a learning environment assuming that I can just do the same thing I always do and trainees will adapt to me, I have failed that trainee, is the way I perceive it. I need to figure out who they are and what they need and try to give them that such that we can progress towards this goal of independence. And if I haven't done that, then I haven't really, fulfilled my role as supervisor.
I appreciate that. And I'm going to disappear in the background again, but thank you.
Perfect.
very last chance saloon for any remaining questions. Okay. Well, thank you, David, again for just a really wonderful presentation, for sharing your work and knowledge with all of us. And I will turn it over now to Dr. Ken Steinberg, our inaugural Vice Chair of Education in the Department of Medicine, to present the Evans Award.
Thank you, Adrian. And oh my gosh, thank you, David. What a fantastic presentation. It was really terrific. Hi, everybody. I'm Ken Steinberg, and I am the Vice Chair for Education. And I, along with Jenny Wright, who just joined, who is the clerkship director, the student clerkship director, are privileged to present this year's Evans Awards. So let me share my screen. Okay, great. I hope everybody can see that. The Robert S. Evans Awards, or the Evans Awards, are presented every year to an outstanding graduating medical student and a second-year resident. The award recognizes the special qualities of warmth, understanding, compassion, and concern for the needs of others that were exemplified by and expressed throughout the life of Dr. Robert S. Evans, also known as Bud Evans, who served for many years as the very first chief of medicine at the Seattle VA. Bud Evans was revered by everyone at the VA and in our department for his kindness, compassion, his humanism. And unfortunately, he died tragically in 1974 in a car accident crossing Lake Washington. And this award was created to honor him. He is also known, and many people don't know this, he's also known for the syndrome that bears his name, Evans syndrome. And Dr. Evans published this paper on primary or idiopathic thrombocytopenic purpura and acquired hemolytic anemia, now called Evans syndrome after him. The Evans Awards have been handed out for the last 50 years, since 1975. And here you can see just this amazing of people who have received this award over time. Some years, more than one award in each category has been given out, but you can just see this list over time. And so with that, I want to present the 2025 Evans Award recipients. Just a note, the committee is made up of about 10 people from all different sites in our system and from people affiliated with both student and residency training. It's my privilege to present the second-year resident Evans awardee. And before I tell you who that person is, I want to share a few nominations. Actually, I was so impressed this year. We received 23 nominations. 23 people were nominated from the R2 class. And that's more than half of the R2 class, which just tells you the kind of physicians that we have in our training program. Most had one or two nominations each. The winner received 6 nominations. And quotes from those nominations very briefly: "This resident is the embodiment of positivity and warmth. She consistently uplifts team morale and selflessly prioritizes the needs of others over her own. Her kindness, compassion, and unwavering positivity shine through in every interaction." This resident is the equivalent of a human ray of sunshine that can brighten even the darkest of Seattle days. This resident is incredibly positive, is an incredibly positive and bright force inside and out. Her warmth towards others is absolutely contagious, and she is kind to her core. And it's my privilege to announce that Serena Sandhu is the winner of this year's R2 Evans Award. And I don't know if she's on. I hope she is, to have heard those wonderful quotes. With that, then I will turn it over to Dr. Wright to announce the MS4 awardees.
Thank you so much, Ken. Is everyone able to hear me? Perfect.
Yes, I
Okay.
can. Yeah.
So I'm going to take it over from here. Thank you so much, Ken, and announce the MS4 awardees. By saying awardees, you're getting a hint that we could not settle upon one single person this year. We had many wonderful nominations come in for medical students. We loved reading through all of them, could not decide on a single individual, and ultimately decided to give 2 student awards this year. So our first awardee had 5 lovely nominations from a mix of faculty, students, and staff. And in a similar manner, I'd like to share a couple of those comments with you. This student authentically engages with patients to understand their unique stories and collaborate with them to improve their healthcare outcomes. Like Dr. Evans, she believes in the interconnectedness of all individuals and approaches patients, colleagues, and community members alike with warmth, care, and fostering a healing and inclusive environment wherever she goes. Another comment was that they cannot speak highly enough of the students' level of engagement and how it aligns with the attributes of Dr. Evans. She is hardworking and humble and consistently models warmth, understanding, and concern for others. She has been engaged in meaningful longitudinal community service and the care of those on the margins throughout her time in medical school. So our first awardee, MS4 awardee, is Sophia Shaheen. And I don't know if she could be here with us today. She's currently in San Francisco, where she's going to be attending residency at UCSF. And Sophia, we hope you come back here and join us in Seattle in the future. Our other awardee is someone who also had many nominations, again, from a mix of people, including students, residents, and faculty. A few about that student or this student. She exemplifies hard work, dedication, and humanity in medicine. Not only did she found bedside concerts to bring music to the critically ill, but she has excelled in all clinical domains and earned the respect and admiration of her peers. The student was also described, similar to Serena, as a ray of sunshine, thoughtful, supportive, and nice to everyone around her. And a final comment I'd like to share is one regarding, again, her musicality. She has volunteered her beautiful singing voice to gift songs to hospice patients, and is the kind of student doctor who drove to Dick's to get one of her dying patients a milkshake. So this second awardee is Jory Wittig. Hopefully she can be here with us today to hear those lovely comments. We look forward to working with her in our UW internal medicine residency this year.
Yay. Yeah. Oh, Jory, thanks for turning your camera on. Serena and Sophia, if you can turn yours on, and congratulations. We're all so proud of you. And as you've joined this amazing, amazing list of clinicians from the University of Washington, I hope you have just a wonderful year coming up, Sophia and Jory, as you enter residency. And Serena, you're going to be in R3. So, all right, with that, I will bring the presentation to a close and stop sharing my slides. thank you everybody for sticking around and hearing the presentation of the Evans Awards. And David or Adrian, any concluding comments, or do we just close?
No closing words besides congratulations to all of our awardees, and another huge thank you to David for his outstanding presentation today. And everyone, I hope you have a great afternoon. Thanks all.